Until we otherwise rule out spinal cord injury, it's always assumed when the patient experiences or sustains brain trauma, we also assume the patient had spinal cord injury because the head sits on the spinal cord and vice versa. So when we suspect spinal cord injury, we also assume head injury unless otherwise ruled out. So spinal cord injury, there are many forms and causes of spinal cord injury. Our focus here is on the effects, what our patients will, what patients' limitations will be depending on the level of the injury. Our management, beginning from initial to ongoing to rehab. So there's a table here. Let's go to manifestations. So the causes would be, of course, trauma. Sometimes the only non-traumatic cause of spinal cord injury is from an epidural. So a patient who receives, let's say a patient in labor receives an epidural, and then the provider inserts the needle either too deep or at the wrong level of the vertebral column, causes spinal cord injury. So that's pretty rare though, but most causes, of course, is trauma. So car accident, falls, similar to what happened in traumatic brain injury. Okay, so same causes. Let's go to the clinical manifestations. The first chart, 63-7, we're not testing. So these are talking about syndromes. Let's go to the other table, which is, let's just go down the list before I go to the limitations. So in order to diagnose spinal cord injury, we need the same as head injury. So we need a CAT scan or an MRI to prove the existence of the injury, coupled with the patient's manifestations as well. You still remember the acute emergency, which is neurogenic shock. Okay, so this is the only shock caused by spinal cord injury. What are the manifestations of neurogenic shock again, besides low blood pressure? Bradycardia. So this is the only type of shock that has bradycardia. Okay. So let's go with emergency management. So at the scene, the patient may have sustained, if it's a car injury, car accident or a fall, or got mugged, for instance, or got shot, okay, or fell on the snow, for instance. Okay, whatever the patient sustained. So at the site of injury, so wherever this occurred, patient is likely to receive first aid, correct? Until the ambulance comes in. So proper handling of the patient to prevent further damage to the injury. Because if you move the patient, sometimes that will exacerbate the injury, correct? Improper movement. People mean well, but untrained people will automatically move the patient, not knowing that the doing so could cause possibly death. Okay, if the neck is not stabilized properly. So at the scene of injury, so trained personnel will quickly immobilize the spine with a rigid neck collar, then place the patient in that's why we have stretchers, we have backboards, okay, to make sure the patient is immobilized. And the priority assessment, of course, is ABC, correct? So we ensure airway, breathing, and then circulation. And then we look for other injuries, okay? But the priority is to immobilize the airway. And then once we ensure breathing is okay and that there's no blood loss, for instance, then we immobilize the spine. Okay, and then the entire spine, not just the neck, but the all the way to the sacrum.
Question, Professor.
Yes.
Can also a nurse put in color, or is only the doctor or EMS?
Can put in what?
The neck brace.
Yeah, and any first responder.
Okay.
right?
Oh, what's
But
the
nurses
difference?
usually are not the first responders, right? I mean, the EMTs
I
or
know
the
EMTs,
paramedics.
they come with it,
Mhm.
but the nurses sometimes they say they're not moving if the doctor have to do it.
I know, it's just simply applying the collar. You don't need an
Oh.
order actually to do that.
Oh.
Because we can easily remove it. I mean, it's not invasive. Right? So here is the testable table. So again, the earlier chart 63-7, we're not testing the syndromes. This one is testable. So you'll see this on the blueprint. Patients' sensory motor limitations by level of injury. So this testable part is the effects on the patient. So C1, for instance, what can the patient do? So the questions will go patient sustained. I'll give and specify the level of spinal level involved. Let's say if it's which cervical, which thoracic, which lumbar, for instance. Question will be what can the patient do? What meaning you need to be able to know what the patient can do so that in your care, so your interventions are proper. For instance, can you get a C1 spinal cord injury patient out of bed? No, they can hardly breathe. See here, no control of the head and neck. So no diaphragm control. So is this patient on a ventilator? Yes, because the phrenic nerve is innervated where? At C4 level, right? C3, C4. So no phrenic nerve innervation, then the diaphragm cannot move, correct? All right. So the way I remember this is I went backwards actually. I went from here. I remember from school, I went from sacrum first and then go up because I know anything below that is no function, right? So meaning it's easy for C1 right here. So let's say C1, I know anything below that, nothing. All right, so there's no breathing, there's no spontaneous breathing. Of course, there's no bowel and bladder control. There's no arm or leg movement. Okay, so the way I went, I just remembered that. I mean, that's how I remembered it is from sacrum. So I went backwards. So here, so which injury, for example, which patient is able to use a manual wheelchair? Okay, so if you look at the last column, so here for C5, so that's around your shoulder blades right here. So the patient is able to use shoulder controlled electric wheelchair, meaning the controls are here. They're able to move their shoulders. But for finger, I mean, hand control of the motorized wheelchair, it's C5 minimum. Okay, so electric or modified manual wheelchair, because the patient still has full head and neck control, some shoulder strength, and elbow flexion. So there's no evidence here of finger use, hand and finger use, but we can modify wheelchairs now. It's the 21st century. We can do a lot with wheelchairs. So next question is, possible question is, which patient can drive? Because remember, cars now don't have to have foot pedals in order to drive. Yeah, everything can be done by hand. So the accelerator and the gas pedal and the brake pedal can now be controlled by hand. So can a C6 patient drive a car? Yes, so see here, they have full innovative shoulder, wrist extension, and dorsiflexion. So they can do that now. So therefore, they can drive a car, right? Yeah, so full arm movement here, independent with assistance. So I mean, they can transfer from the bed to the wheelchair. I'm sure they can drive a car, a modified, what is that? A what do you call that? Signs for parking?
Oh, the disabled. Disabled, disabled.
Yeah, something like that. Yeah, so it's a modified car. Okay, so we can have cars with hand control. So they technically, yeah, they can drive a car.
So, Professor, those who's in the chair, like the mobilized chair, you see the electronic chair, and who have a neck back that holding the head up.
No, those patients are probably I would say C3, C2, C3. But the controls there would be the shoulders. That's the fire alarm.
Oh.
Okay, so here, so those are C4 patients, shoulder controlled electric wheelchairs.
Oh.
All right, so this is how this is tested. Okay, what can these patients do? All right, so it's not true that only paraplegics can, no, paraplegics meaning waist down. And they're not the only ones who can drive a car, right? So we have up to C5. Okay. No, not C5, C6 because C6 have independent transfers. Okay, so C6 at least can drive a car, modified car. And here are we already know ABC would be your priority, assessment and interventions. For drug therapy, look at the first statement. Steroids, when we say steroids, it's really methylprednisolone. In head injury, what steroid was used? Dexamethasone, right? Yeah. So for spinal cord injury, it's methylprednisolone. However, look at the statement again. It's controversial. Not all patients not all facilities are now going to administer steroids because they question the benefit of steroids in a spinal cord injury patients because yes, steroids will decrease inflammation, but as this statement shows, steroids are no longer considered part of standard care during the acute period of injury.
Is it due to side effects?
Yeah, it's not really found to have a profound benefit. I mean, it doesn't shorten the period of inflammation in the spinal cord injury. There's no evidence. So basically, more side effects than benefits. Literally almost zero benefits. So if something doesn't work, then why give it? So respiratory therapy only if, of course, the patient needs it. So this is around C1 to C3, which will require oxygen supplementation. C1 definitely needs to be intubated or at least tracheostomy. We'll do the traction later. Our traction will be the halo vest, and that's specified in the blueprint. So when we say traction, so we're talking about cervical injuries, okay, to immobilize the neck. So we'll talk about the halo device and its care. There's a full table or chart on it. Oh, right here. So this is the halo vest. So this is for cervical injuries. To immobilize the neck, the patient will be, this is a form of external fixation device. So these screws you see here are drilled into the patient's skull, but because they have pin sites, so that means we'll have to do pin care, which is not any different from any other external fixator. So whether it's the external fixation with screws are in an arm, a leg, same care with the pin sites, which is we wash it with saline, we irrigate it with saline, and around the site we will apply betadine ointments to retard bacterial growth, and that's done once a day. The patient wears this pretty much 24 hours, but technically it's 23 hours to help us do hygiene. So we can take off the vest to provide skincare, to change the shirt. Okay, so that gives us about an hour. So when the vest is off, the patient must wear a rigid neck collar, okay, during that 1 hour period that we take it off. How do we take it off? There's a wrench in the back because these are not regular screws. The vest has a special wrench, which is always attached to the back of the vest for emergency purposes. So let's say this patient sustains cardiac arrest, we need to do chest compression, so we need the vest off. You can't compress the chest with the vest on, right? So the wrench is always attached in the back. So you need if you need whenever you need the wrench, then it's available, okay, to unscrew the vest and perform chest compression. I have no questions on surgical management. Let's differentiate spinal from neurogenic shock. Neurogenic shock, you know, so this is a true medical emergency characterized by hypotension, decreased oxygen saturation, and bradycardia. Now, for spinal shock, it's not a shock at all. I don't know why they even call it spinal shock because it's not shock. So spinal shock is the sudden depression of reflex activity. Basically, this results in paralysis. So loss of sensory motor function below the level of injury. There's a good thing about spinal shock. If it's spinal shock, that means the loss of sensory motor function is temporary. How long it lasts, nobody can tell, not even the doctor. So if you watch, the perfect example in the movies here is who watched the season 3 of Cobra Kai? Anyone know Miguel? The character there of Lauren's new student? No, you don't know. Okay, anyway, so the kid fell from the second floor. On his way down, his spine hit the handrail of the stairs. So he broke his back and he was paralyzed from the waist down. They thought it was a permanent, but apparently it was only spinal shock because months later he regained function. Yeah, he regained and then he started fighting again. He started training. Right. So that's what spinal shock is. Again, let me emphasize, nobody knows if it's spinal shock or not. Obviously, if the MRI shows exact trauma, or let's say the spinal cord is severed, of course, that's evidence that it's going to be permanent, right? I mean, can you fix the spinal cord? No. However, if there's just bruising or swelling of the spinal cord, then it's possible that the sensory motor loss is simply spinal shock. The period, though, can range from 48 hours to weeks to months. Okay, we don't know when the spinal shock will resolve. Any questions between the difference between spinal shock and neurogenic shock? Which one's the true medical emergency? Neurogenic shock. VTE, which we will cover on the respiratory topic of pulmonary embolism. So we'll postpone this for now, but this is common in any immobilized patient, not just spinal cord injury. So burn patients, any critical patient who's bedbound are at risk for DVTs. So this one even talks about pulmonary embolism. Know though that in musculoskeletal injuries, fractures, for instance, especially spinal cord injuries, there are other causes of a pulmonary embolism, but the chapter we will be discussing will only focus on PEs caused by a blood clot. Okay, not because a PE can also be caused by fat embolism. air embolism, we have foreign debris. So anything solid running around the bloodstream, which can be big enough to obstruct blood flow in one or more pulmonary arteries, of course, will cause pulmonary embolism. And you know this, right? Legs should never be massaged, especially if there's a swelling on the leg or a patient complains of pain on that leg. Okay. We'll talk about one other emergency, which is autonomic dysreflexia, shortly. The nursing care, of course, will be nothing different from head injury. So we have ABCs, checking for other injuries besides the spinal cord injury, and preventing complications related to immobility, which are pressure injuries, no pressure ulcers, DVT precautions, DVT prevention, there is pain management here because the patient will experience some spasms. Okay, muscle spasms will occur. And then the most dangerous among these is the autonomic dysreflexia. Well, let's go to that next. Oh, we were interrupted by the halo vest here. Okay, so let's do the halo vest first. Maybe. Okay, so there's actually a chart, but since the discussion is also here, so let's discuss it now. So there are 4 pin sites on a halo device, all on the skull. So all around the skull above the level of the ear. So they are cleaned daily, and then we watch and monitor the pin sites for any signs of infection because the pin sites are around the back of the head as well. So there's hair there, correct? So the scalp will have hair, although we shaved it when we screwed the traction into the skull. However, hair will grow, correct? It will grow back. So we need to keep the site clean daily. So this is the torque screwdriver I mentioned earlier. This is always attached to the back of the halo vest. These are things not to do. Is do not put any powder. I know you want to keep it comfortable. The cloth on it is sheepskin, but the patient does wear a shirt under the vest. But it can get sweaty. Okay, it's hot. As with any other vest you wear, it's gonna cause sweating and itching. When you start sweating, then it itches. Here's autonomic dysreflexia. Now, this is a emergency characterized by, there are 3 things here that will occur. So the patient will have a sudden severe headache. Now, the sudden severe headache is caused by severe hypertension. So the blood pressure here goes over 200 millimeters of mercury systolic. 200, 210, 220. So the one patient I saw develop this had a blood pressure of 220 over 120 something. He was a paraplegic. The condition does not occur during the initial acute period, meaning if the patient had spinal cord injury and they're admitted today, okay, so during this hospitalization, they won't develop this. This will only develop after the spinal cord injury, the initial injuries have already healed, meaning patient could be at home or they could be readmitted for something else. But basically, it does not happen during the acute episode. Patients already discharged, either at home or that rehab facility. So these are paraplegics because this will only happen to injuries above T6. So T6, these are paraplegics, right? Yeah. Paralyzed from the waist down. So it only happens to injuries above T6. So if the injuries T7 or all the way to sacrum, they will not develop this. So this only if the injury is above T6 level. Okay. So the condition is caused by, that's why it's called autonomic hyperreflexia or dysreflexia, is above the level of injury where you still have an intact spinal cord, and therefore the impulses from the brain are intact, correct? That part of the body will still have sympathetic response, correct? Because the spinal cord is intact. However, below the level of injury, nothing, correct? Okay. Now, these are again the manifestations. The patient, number one, will complain of a really bad headache. The hypertension here again is about 200 systolic or higher. They'll have profuse diuresis only above the level of injury. So there will be no sweating below the level of injury. The waist down will be completely dry, no goosebumps, nothing. But above the injury, patient will have goosebumps, diaphoresis, and sometimes flushing. The nausea, vomiting, again, and congestion, again, is brought about by the severe hypertension, meaning these are manifestations of severe high blood pressure. And just like with neurogenic shock, there is bradycardia.
This what cause fecal impactment?
We'll get to the triggers shortly. So what could possibly go wrong if the patient's blood pressure goes sky high? A hemorrhagic stroke. Okay, so that's what will kill this patient unless we treat the condition. So who does this occur to again? Who are what kind of patients then? Paraplegics. Okay, so paraplegic patients. Quadri is all four, correct? Or tetraplegia. So these are paraplegics, patients going on wheelchairs, all right? So do they, live a normal life, basically? Do they go drinking? You're paralyzed, you're half paralyzed, you're not dead. Okay? Yeah, they'll go party, okay? Yeah, they can even have an erection still, okay? They can still have sex, okay? Not normally.
She has a girlfriend and I was wondering what was she doing with him? No.
Yes, they can. Yeah. I mean, it's not gonna be on demand, okay? Don't get me wrong. It's not like you think about something and then they get an erection. It's not like that anymore. It's gonna be hard work doing it. Okay, so they have to stroke, the penis. There's, they have to work hard in order to get the penis to get an erection. Okay, but yes, they will still ejaculate, but only reflex though. Nothing here. All the pleasure will be here. Okay, nothing physical because they don't feel it. Yeah, they don't feel it. Okay.
I was wondering.
Anyway, enough about that. So what will trigger the condition? Now, let's look at these conditions. Let's say bowel distension, constipation. Your bladder is full. You're sitting on your testicles. You're having an ejaculation. There's a sharp object pinching your skin. You have a large wound somewhere below your waist. Are these conditions minor or major? Meaning stimulation-wise. No, the sensation. Can you ignore a full bladder?
No.
Constipation. I mean, I don't know what constipation feels like because I get diarrhea. I've never had constipation. But four of my sisters are constipated and they say, it's really yeah, it's miserable. Okay, they're miserable. I grew up around those four, and all I heard is complaint about constipation. And that whereas all my brothers, me included, we all have diarrhea. Okay, so we can't relate. When they talk about it, and they say, sorry, we can't understand what you're saying. Okay, because none of us experienced that. So when you have an orgasm, for instance, or ejaculation, all right, so are these things you don't, you don't care about, or will these stimulate sympathetic response? All of these will stimulate sympathetic response, meaning a full bladder, a fecal impaction, orgasms, a pain, especially, all stimulate the sympathetic response, correct? Yes. However, the patient can't feel it. Remember, these are paraplegics, right? And because they're paraplegics, can they empty their bladder normally? No, they'll have to catheterize in order to empty the bladder. They'll need, if not a large regimen of a bowel regimen, meaning they have to take stool softeners, fiber, laxatives in order to have a bowel movement every day, or sometimes manual disimpaction. Okay. And then if they're sitting, because they have no sensation waist down, so are they aware that they're sitting on their balls? No. Okay. So are they, can they feel if they have a large pressure ulcer there? Okay. So tight clothing, like there's a tourniquet. Okay. So these are things that happen to paraplegics, correct? And they have absolutely no idea that it's happening, correct? They can't feel any of these things. However, just because they can't feel it, does that mean the brain cannot receive the signal?
Yes,
The brain is receiving the signal, okay? Meaning the sympathetic response is being sent to the brain, but the patient just has no perception of any of these sensations. However, it will trigger an autonomic response, meaning it will trigger a massive sympathetic response. That's what's responsible for these manifestations. So these triggers can result in the symptoms, the severe hypertension, the bradycardia, all right? So this is what's responsible for the trigger. And then the patient has no idea that they're about to die. They're about to have a massive hemorrhagic stroke. But they just have the, the headache and the diaphoresis. And the patient could die anytime. So the response, of course, once you identify the manifestations, okay, the paraplegic, you see, oh, severe headache, severe hypertension, bradycardia. So these are symptoms, right, of the autonomic dysreflexia. So these are your actions. First thing is place the patient in a sitting position, which is how many degrees? 60 or higher, right? Is 45 sitting? No, 45 is reclining, right? Okay, so 60 degrees or higher is sitting position. Because remember, these are paraplegics, so they're not going to be standing, right? So they're not going to, you don't sit the patient down because they're already either sitting or in bed. Okay, so place them in a sitting position. And then the next action is, we'll come back to the halo vest. Is you're going to identify, so you already know, okay, it's either a full bladder, a fecal impaction, so they're either they're sitting on their balls or there's some sharp object causing pain, some restricted clothing, or it could be a pressure injury, for instance. So those are what you're going to look for. Luckily, the bladder, a full bladder is 9 times out of 10 the cause of the condition. Okay, you're lucky. What if it's fecal impaction though? So you're gonna have to get dirty because you're gonna have to get rid of that fecal impaction. But again, thankfully, most common trigger is what? A full bladder, which is the case with mine. So my patient, we were just straight cathing him because he was diabetic. So he frequently comes in. We know him pretty well because he's, a drinker. He parties a lot, and then he comes in for HHS. He's type 2 diabetic. And type 2 HHS, what's the treatment always? Come on, DKA, HHS, what's the first intervention? No, not even the insulin yet. What's the first priority? Fluids, right? Yeah, lots of fluids. Okay, so lots of fluids, and then the insulin with dextrose, right? Okay, yeah. So anyway, no, not insulin with dextrose. Insulin, regular insulin IV. Sorry. and all that. So therefore, when he came in, was he in AKI? Yes, okay, DKA patients going to AKI, right? So they had little to no urine output. So it was fine during the first 24 hours. But the next day, we didn't anticipate he was already in the diuretic phase. So we were still straight cathing him 9 a.m., 9 p.m., not knowing he was already in the diuretic phase. So when I saw it, no, I saw the trigger. Hey, I've only seen this in textbooks. Hey, and then I told the patient, hey, what you know what you're having? Autonomic dysreflexia. Okay, so I was very excited, and then it occurred to me. I didn't say it, but I said, yeah, you could die. Okay, so I looked at the bladder. The bladder was this big. Okay, and then he couldn't feel it. So I didn't even get that order yet. So I just said to my charge nurse, hey, this is autonomic dysreflexia. And then I called the tech to get me a Foley. Then, I was just, I mean, I know the doctor. I know he's gonna give me that order. I mean, the bladder is this big. What else is he gonna tell me to do? Okay. So I inserted the Foley, drained it, and then immediately he was already sitting. So I didn't have to do the first stop. But I did do the second, so I didn't have to do this because he was already sitting. Then I emptied the bladder, and immediately the blood pressure went down.
So it's, while you were doing your assessment that you decided to check the bladder?
Yeah, because there's, again, 9 times out of 10, the textbook says
Says
it's
bladder.
usually the bladder.
Oh,
And, I just got lucky when I took off the sheets, the bladder was right there.
Oh.
Right?
But Professor, for patient with paraplegic, which is don't have no sensation down here, if they're constipated, as it as you always have to monitor the bowel, because they won't be able to feel it to tell you.
Yeah.
Yeah, because we had a patient once and then,
Mm.
I didn't know at that time because I helped the nurse to administer enema and then, but he was paraplegic and he had his blood pressure was sky high and then she thought we can help her administer enema. So now I'm thinking this is the reason why she
Yeah.
was doing it.
Mhm.
Because if you have about movement in days, the blood pressure was super high.
So even though they talk, so literally you have to always check it.
Yeah.
Yeah.
That's why you have
So
to
all
document it.
paraplegics, okay? All paraplegics are this way. Are quadriplegics at risk for this?
I think so. don't you?
So it's above T6. So yes, quadriplegics and paraplegics. Okay, so always remember, so when you have these patients, it's always good to have a bowel and bladder regimen, okay, because those are the most frequent
Yeah,
triggers. So you look for the other possible triggers. Check the rectum and check the skin. Anything that will cause extreme pain, for instance. And if the measures, the sitting up and then emptying the bladder or emptying the rectum does not drop the blood pressure, then the doctor will give you, usually it's going to be a calcium channel blocker, IV, that will be given. Or sometimes they'll give you hydralazine also, which is a vasodilator. But anyway, we need to drop the blood pressure, obviously. And then if the patient survives it, hopefully the patient will survive, then we put it on their medical record that the patient had autonomic dysreflexia. And
So
then,
at risk rate, if they had it already?
Hmm?
If they had it already, they're at risk?
yeah, because it happened once, it will happen again and again. So now the patient will receive on their plan of care, it's going to be always, the bladder and the bowel.
Professor Sterling, so when we do empty out the bladder, empty out the rectum, it's automatic that the blood pressure drops?
Yeah, sometimes they'll need antihypertensive medications,
They'll still
IV,
need
yeah.
medication.
But not all the time though. Sometimes, I mean, I don't know because I only had it I only had one episode, and for him the blood pressure dropped, so I didn't need to give him any medication. So for his case, that it was the bladder really. I emptied 2,700 out of that bladder. No idea a bladder could hold that much. That's about it for spinal cord injury. Any question? Oh no, sorry. Last topic is the halo vest. Almost forgot. So here's your care. So starting with the pin sites. Okay, make sure pin sites are assessed and you have prophylactic antibiotic ointments around them. Check the skin under the vest, under the chest. And make sure the patient understands that the vest is always on, especially if they're out of bed. Otherwise, during the removal for hygiene, then they can have the yes, they can shower with the you remember that 1 hour that they're off? Yeah, so they must be wearing the cervical collar. Now, of course, you can't take off. Don't get me wrong. The only thing you can take off is the vest. You cannot take off the pin sights. Okay, so they will always be on. I mean, how do you unscrew it? The doctor is the only one who can remove the screws. Okay, so only the vest can be removed. Okay, for hygiene, and then they'll change their clothes. All right. Any questions? Very good.